Afternoon, everyone. Good afternoon, everyone, and thank you all for joining this webinar. If you would like to show your flag, where you're joining from, or which country you're from, you can do that. So, thank you all for coming. Radhika, who is our presenter, is a board certified genetic counselor working in New York State. She earned a dual bachelor's degree in biology and psychology from Boston College and a master's degree in human genetics from Sarah Lawrence College. Radhika has a long relationship with the Cooley's Anemia Foundation, first as a national director of patient services and then as fundraising chair for the Long Island chapter. She was nominated to the board 5 years ago and has recently been elected to the executive committee. Radhika is passionate about outreach and advocacy with a specific interest in thalassemia. Radhika?
Thank you, Steve. So I'm going to share my screen and so we can talk a little bit about thalassemia together. So if you'll bear with me one moment while I start it. Okay. Hopefully you all can see the screen okay. Steve, are we seeing it properly?
Looks good.
Okay, thank you, Craig. Well, again, good afternoon to everybody. Good evening. Thank you so much for joining us today. And thank you, Steve, for that very generous introduction. My name is Radhika Sao, and as Steve mentioned, I am a board certified genetic counselor. And as a genetic counselor, one thing that I focus on and I strive to do every day in my work is to empower people through education. So being invited to do this webinar today, fills two goals of mine, education and focusing on improving awareness about thalassemia. So I'm really grateful to be here today. So I want to start off by talking a little bit about the organization that is hosting this webinar, and that is the Cooley's Anemia Foundation. So for those of you who are not familiar with the Cooley's Anemia Foundation, they are a 501(c) nonprofit that is dedicated to serving people afflicted with various forms of thalassemia, most notably the major form of this genetic blood disease that's sometimes known as Cooley's anemia, but often referred to as thalassemia major. So Cooley's Anemia Foundation was formed in 1954, actually in the back of a butcher shop in Brooklyn by a gentleman named Frank Ficara and the parents of a few other patients who met to decide how they were going to help support their children. And from that meeting, the seeds of what we now know as the Cooley's Anemia Foundation were sown. And you may be wondering, if we are focusing on thalassemia, why is it called the Cooley's Anemia Foundation? And that is because the Frank and the other parents wanted to pay homage to the doctor who first discovered and described this condition among four children of Mediterranean descent, and that is Dr. Thomas Benton Cooley, who you see up on your screen now. So that is why it is called the Cooley's Anemia Foundation. And for now more than 70 years, they've been leading the fight in the United States against thalassemia. So we're really grateful that they have put together this webinar here to educate us all about thalassemia and how it impacts those who are from the Caribbean. So let's talk a little bit about thalassemia. So for those of you who aren't familiar, thalassemia is a name of a group of genetically inherited blood disorders in which a person is born with hemoglobin, which does not function correctly. And you may recall from your time in biology class that hemoglobin is a molecule that's found in our red blood cells. And hemoglobin is very important because what it does is it carries oxygen from the lungs throughout all the body's tissues. So hemoglobin is absolutely essential for life. So if we don't have working hemoglobin, we can't get oxygen to our tissues and our organs, and then we can't survive. The important thing to remember about hemoglobin is that it's composed of two different types of protein chains. One is the alpha chains and the other is the beta chains. And that's going to be important because what it is with thalassemia happens when there's a mistake in the genetic instructions to make one of those two chains. So if we don't make enough alpha chains, we have what's called forms of alpha thalassemia. And if we don't have enough of our beta chains, we can result in beta thalassemia because we need both those chains that have to be in the right proportion in order to have healthy functioning hemoglobin. And if we don't have the right number of chains produced, then the hemoglobin cannot function, and then we don't get the oxygen throughout the body, and we have what's called anemia because our red blood cells aren't able to do what they're meant to do, and then they get destroyed prematurely. So, as I mentioned, there's something called alpha thalassemia, and that's when we don't have enough alpha thalassemia made. So, alpha thalassemia is interesting because there's actually four genes that are there present in typical healthy humans that make up the amount of alpha globin that we need for healthy hemoglobin. But it's interesting because there's four copies, people can have one or two missing or not functioning genes, and they can still be healthy. And they have what's called alpha thalassemia trait. So you see here, we have two copies of our genes. We get of our chromosomes, excuse me, one from mom, one from dad. And on each, you see we have one, two of our alpha globin genes. So if you're missing one or even two, you can still be healthy because you're making 50% of what you need. But the problem is if someone who's missing two copies has a child with someone who's missing one copy and they pass them down like this, they can have a child born what's called hemoglobin H disease, where they're only making 25% of the alpha chains needed. And then they can have a child who has health issues and they can require blood transfusions to live. So this is why, again, you need the right amount to be made. And you can also have sometimes, if again, we have a parent who has two missing alpha globins, pass that chromosome to their child, and the other parent, same thing, passes their down to their child. Now, this child has no working alpha globin, and that can be incredibly devastating, and that child will need transfusions even before they're born in order to live. So it's really important for us to understand if parents have alpha thalassemia trait, because they can have children who have health issues. They themselves will be healthy, but their children may have this condition. And it really is a matter of odds. It depends which chromosomes we pass down, the ones that have working alpha globins or the ones that have non-working. And that's not in our control. That's just chance. Beta thalassemia is more typical of our the way our genes are, where there's two copies, one on each gene, as opposed to alpha that had four copies. This only has two. One we get from our mom, one we get from our dad. Now, in this case, if the individual has only one working and one non-working, they have what's called beta thalassemia trait. And again, 50% is enough. They're fine. They're healthy. They might have a slightly mild anemia, but otherwise they're healthy and their health will not change. But if two people who are both trait carriers have a child together, they have a chance of passing down both the non-working copies, and they can have a child born with what's called beta thalassemia major or beta thalassemia intermedia. And both of those conditions will require blood transfusions. It just depends. Sometimes they require them constantly, and sometimes they require them infrequently. So there are these conditions that happen. So it is really, really critical to know if a couple are both carriers of these thalassemia traits. Okay. So they themselves would be healthy, but a child who does not make the right amount, if they make less than 50% of either their alpha or their beta globin chains, they will have a more severe form of thalassemia, which can be oftentimes blood transfusion dependent. The problem is when you get blood transfusions all the time, your body ends up with what's called excess iron. Because traditionally, what we do with our blood cells is they live about 120 days and then they are destroyed, and the body recycles the iron to make new red blood cells. But in the case of people with severe forms of thalassemia, they don't have the right hemoglobin, so they're not recycling that iron like they should. And the problem is they're getting so much iron from the transfusions that they're getting, it's more than the body can utilize. So they end up with this excess buildup of iron. And the body has no way of naturally removing iron, so it can build up into different organ systems and cause damage. All right. The only way it can be removed is through a process called chelation, which requires either infused medications overnight or oral medications that have to be taken regularly. If not, that untreated iron overload can lead to a host of complications, including heart or liver failure, diabetes, osteoporosis, osteopenia, pulmonary hypertension, growth or developmental issues, and fertility pregnancy issues. Because the problem is iron likes to deposit in our organs. And when iron is there, our organs cannot function as they should. So it's really, really important that people who have these severe forms of thalassemia that require regular blood transfusion have to then deal with taking chelators to remove the iron to avoid complications. And I will say this is critical that now we have chelators that can be used. Prior, people didn't have these medications, so the blood transfusions that helped them survive also inevitably led to their death because of this iron overload. And the number one cause of death oftentimes was cardiac failure because the heart couldn't pump with the iron buildup. But thankfully now we do have chelators, and that can help now improve the life of people with thalassemia and help them avoid these complications. But you may be thinking to yourself, okay, this is great, but why is this important to me? Well, it's important because of the makeup of the people of the Caribbean. The Caribbean is one of the most ethnically diverse regions in the world and is composed of a mix of people with African, European, Indigenous, and Asian ancestry, which is the direct result of centuries of colonization, the transatlantic slave trade, and indentured labor. And as you see here on this map, thalassemia is very prominent in people who hail from Europe, parts of Africa, the Middle East, and Southern and Eastern Asia, all ethnicities which can be found in the Caribbean diaspora. That's why it's really important that our Caribbean community is aware that they could be carriers of thalassemia and what this implication is for their children. So it's really important that we recognize it. It is oftentimes, in the Caribbean, we do have a lot of people of African descent, and people oftentimes recognize that people of African descent are at risk to have hemoglobin S, more commonly known as sickle cell. But people don't always know that, if you're of Asian or European descent, or even African descent, that you can also be at risk to carry thalassemia. So that's why we're here today to talk about it. And when we think about here in the United States, how many people do we know that have the severe forms of thalassemia? Well, according to our latest counts, it's between 2 and 3,000 people, but more than 2 million people are estimated to carry some form of thalassemia trait. And most of them have no idea that they are carriers until they end up having a child who's affected because they ended up having a child with someone else who is a carrier. So that's why we're here today, to help educate you and to tell you that finding out if you have thalassemia trait is very, very easy. All you need is a very simple blood test called a complete blood count that you can ask any doctor to do for you. Your primary care may do it when they do your annual blood work anyway. And you ask them to look at what the MCV, the mean corpuscular volume, which is one of the values that you'll see on a CBC. If it's under 80 and you're not iron deficient, you could have thalassemia trait. And there's a simple test that you can do to follow up called electrophoresis that can confirm whether you have thalassemia trait and what type we're dealing with. So it's a very simple test that can really have implications and help you to understand, if you're feeling a little anemic, is it because of a genetic form or is it maybe because you're iron deficient? But more importantly, if you're at a time where you're trying to start a family, are you at risk to have a child with a severe form of thalassemia? So some really important facts that I just want to make sure you know is that if you do have either the alpha or beta thalassemia trait, you're healthy. You're fine. You will not need any medical treatment. And you don't need iron because iron will not help you to change that. You can't change your genetics. The only reason iron supplements should ever be given to someone is if they have diagnosed iron deficiency. And I want you to know that if you do have thalassemia trait, that's fine. It won't get worse and it's not going to change and become a more serious condition. But what is important to know is that if you and your partner both carry thalassemia trait, whether it's the alpha type or the beta type, and you carry the same type, you can have a 1 in 4 or a 25% chance with each pregnancy of having a child born with a severe form of thalassemia. Now, you know, thankfully there are better treatments that we have today for it, but it's still something you should be aware of that you may be at risk for. And I tell you this because it's not something that a lot of people are aware of. In fact, some of those people that didn't know were the people who I call mom and dad, because my family hails from India, one of the places I showed you on the map that has a very high prevalence of thalassemia trait. And my parents, unbeknownst to both of them, are both carriers of thalassemia. They had what was typical of the time, an arranged marriage. And as far as both of them knew, they both came from very healthy family with no illnesses in them. And so they got married and they came to the United States to start a family and for my dad's career. And what ended up happening is that they had their first child, my brother, and he seemed fine. He seemed, as far as my mom knew, he was healthy. She went to take him to visit her parents who were staying in England at the time. He was about 1. And my grandfather took one look at him and said, "Why is he so pale? Why does he look like that?" And that started a whole trajectory that eventually led to his diagnosis with thalassemia major. And in the US at the time, there were not a lot of Indian populations, so they just didn't even recognize it. It wasn't until the doctors in England brought it up and they told my mom to talk to her pediatrician, that the pediatrician recognized and said, "Oh my God, yes, he does have thalassemia." So my brother ended up having to start on blood transfusions. Unfortunately, as I said, at that time, all he had were blood transfusion. There was no chelator. And eventually he did pass away. And he passed away a few months before I was born. And my parents did not really appreciate the genetics of it. And that's why I'm so passionate about it, because they didn't understand that because they were both carriers, every pregnancy they had would be at this 25% chance to have a child with thalassemia. So they thought they just had unfortunate luck with my brother. But once I was born, I too was diagnosed with thalassemia major. I have had the good fortune, though, unlike my brother, of being born at the right time. Because when I was 5, that's when chelators were became part of the treatment plan for people with thalassemia. And while I started my transfusions at about a year and a half, when I was 5, I got to join a clinical trial where they were testing out chelators on young children. My parents took a leap of faith because the doctors at that time weren't sure how it would work on a child. They thought it would make a big difference and would help me survive and avoid that iron overload, but they weren't sure. but my parents had faith and they enrolled me in the trial, and I started using a chelator. And at that time, it was only injectable, and I would wear it, and I'd have to have it infused overnight for 10 to 12 hours a night. And I did it, and I did it for years. And because I did, and because I used that chelator along with getting my regular blood transfusions, I survived and I lived. And I lived past my brother. I was able to grow and develop, go to school like my peers. I graduated high school. I went away to college. I was able to become a genetic counselor. I got married, and the years kept going by, and somehow I kept surviving. And something I never thought possible is that I even became a mom. And I am thrilled that I've been able to be healthy, and have a child despite having a chronic, health disorder. And even I did something I never thought possible a few months ago. I turned 50. That's not something that we ever thought possible for people with thalassemia, but today it is if you get good care and good management. It hasn't always been easy. It's been particularly challenging now as an adult with thalassemia, finding doctors who are knowledgeable and, having to kind of argue to make sure I get the right care I need. But it's possible now and it's been done. But the thing I realize now is that a lot of people don't know that they're at risk to have this condition and to have a child with it. And while have had a good life, I know other people have had struggles, and I just want people to be aware of what this could mean if they do have a child with thalassemia or if they are carriers. So I hope this has been helpful in explaining that. And I just want you to know that even with thalassemia, you can thrive and have a great life. And to talk a little bit more about her journey, I'm going to pass it on right now to our lovely patient advocate, Chanel. So, Chanel, I'm going to stop sharing and pass it on to you.
So Chanel is from Trinidad. She's an administrative professional with over 10 years experience providing support to management level. Chanel holds a bachelor's degree in business administration from the University of New Brunswick and is currently employed with the government of the Republic of Trinidad and Tobago. She has been an ardent advocate for herself and other people living with thalassemia in Trinidad. She is vice president of an organization advocating for inherited blood disorder, IBD-TNT. As a person living with thalassemia, she uses this platform to raise thalassemia awareness and advocacy at home and abroad. She's an inspiration to others living with thalassemia to make a positive and impactful lives of patients with thalassemia in Trinidad. Chanel.
Hi, thank you so much for the introduction and for the opportunity to share my story. Good afternoon or good evening to everyone who is listening or viewing this webinar. I am Chanel Maharaj, and I was born and raised in the beautiful Caribbean twin island Republic of Trinidad and Tobago. And my journey began when I was diagnosed with beta thalassemia major at approximately 1 year old. It was on a day that my parents had taken me to our local district health facility to have just the routine pediatric checkup and immunization done. And at that time, the nurse whose care I was under recognized that I was looking abnormally pale. So she immediately told my mom that the doctors would need to further assess my condition. And so a series of blood samples were taken, and it was then discovered that I had a low hemoglobin level. Of course, this led to even further investigations. And after electrophoresis testing, as Radhika would have mentioned, and further screening, my diagnosis was confirmed with beta thalassemia major. For my parents, it was the first time they had ever heard of the condition, and it took them a while to understand what this was all about and what it meant for my future. So following my diagnosis, I had started receiving blood transfusions at least once per month, and that was through the pediatric unit at the General Hospital. And this was a process that my family had to learn how to navigate because on treatment days, my parents they had to ensure that I arrived at the clinic around 7 a.m. In the morning, where blood samples would be taken for testing, and then I would usually be seated in the waiting room for several hours until the results were retrieved from the lab, which would then inform whether I can obtain a unit of blood for my transfusion. And usually that would happen later that evening or sometimes going into the night. And then I had to remain at the hospital as well for observation, which meant that in some instances, I had to be warded at the pediatric unit until the next day. From my understanding, this was generally the process until I was around 5 years old. Unfortunately, the availability of blood was not always guaranteed for same-day transfusion in a lot of these instances. So my parents were required to take me to the clinic on another day, which meant that they had to take time off from work. I had to take time off from school, to go maybe later that week or the following week in some cases, with the hope of receiving a transfusion then. So yes, as I mentioned, I was frequently absent from school in order to attend all the clinic appointments and so on. Thankfully, though, I was blessed with understanding teachers and classmates who sometimes assisted in keeping me up to date on the classes and the assignments that I may have missed. And along this journey, my parents, they had the opportunity of connecting with other thalassemia patients who they would have met at the hospital. They met their parents and their caregivers. And some of these families were also members of the Society for Inherited and Severe Blood Disorders. So they introduced us to the organization. My parents, they became registered members of the society and shortly began attending membership meetings and, with the hope of learning more about my condition and the coping mechanisms. And through the organization, we've had the opportunity to meet one of the world-renowned pioneer hematologist, and that is the late Dr. Waveney Patricia Charles. She was like a Mother Teresa to a lot of our patients in Trinidad and Tobago. And after my parents learned of Dr. Charles's impact on patient lives, they sought to visit her private office, where she screened and assessed my parents as well as my older brother, who all presented with a thalassemia trait. The thing about thalassemia is that there are no obvious physical signs, so the diagnosis could only be confirmed through the MCV testing or hemoglobin electrophoresis testing, as Radhika would have mentioned as well. And so a lot of persons like my parents, they would be carriers of the gene, but they don't know it. So Dr. Charles would have done these testing with my family members, and she provided the much needed education um, of my diagnosis and advised further on my treatment and the fact that I had to receive iron chelation therapy as well. After her examination, she also recommended that I remove my spleen, which had already become enlarged from frequent blood transfusions and iron overload. So she advised my parents on the urgency of this procedure, and arrangements were made for me to undergo a splenectomy when I was approximately 8 years old. Thereafter, I continued to receive regular monthly transfusions at the pediatric unit and subsequently iron chelation through IV at that time. We were later introduced to the option of the home treatment via portable infusion pumps and so on, which the society would have aided in sourcing for my use as well. As I grew older, I eventually surpassed the age requirement to be treated through the pediatric unit, and I had to be referred to an adult hematology unit at another general hospital on the island. Fortunately, Dr. Charles was functioning there as the hematology consultant at the hospital. So I started being treated and managed under her care. Um, and I'm still there until present. And oral iron chelation options would have eventually became available. Um, my visits to the clinic currently are usually every 2 to 3 weeks, and this is in an attempt to maintain my hemoglobin level at 10 or above. However, this has been quite difficult for myself and many other patients with thalassemia to achieve because we continue to face a national crisis in Trinidad and Tobago regarding the availability of blood and so on. So for this reason, it has become my mission to work together with the NGO to advocate and to raise awareness about inherited blood disorders and about the importance of blood donation and so on. And we, through the organization, we partner with different stakeholders to conduct um, an annual walkathon to raise awareness, blood donation drives, and other activities that would educate and sensitize the general public. Besides the crisis faced with our national blood pool, we also face the challenge of inadequate access, I would say, and availability of like multidisciplinary care for thalassemia patients. Because you would find that most professionals in the respective specialties, they are not familiar with treating patients, specifically living with thalassemia. So I must mention though that healthcare in Trinidad is available at no direct cost to patients, which means that our public health system is usually quite overwhelmed. And in instances where thalassemia patients are referred to the respective specialty clinics, oftentimes they are discharged once the required testing is done and they do not like present with any severe complications that would warrant being managed continuously through the system. So for this reason, it is usually quite difficult to be reviewed and monitored on a continuous basis by the various specialists. And things like MRI testing, bone density scans, and other testing that is recommended as outlined in the guidelines for the care and management of thalassemia patients. It's also not so available in Trinidad and Tobago. So in some instances, patients would resort to having to do these things at private healthcare facilities or even abroad, um, based on the availability of it. And of course, this is not exactly affordable for the average patient, especially due to the frequency in which a lot of these tests and examinations are required. As it relates to iron chelation therapy, um, most patients are now able to access oral chelation options, which is deferiprone, defersirox, and desferrioxamine. And the society would have also assisted here through, lobbying and so on. So we now have it available through the public health system. In Trinidad and Tobago, one of the things we need to work on as well is to develop a comprehensive national registry of thalassemia patients, because this hinders, accurate data collection and the epidemiological studies. The absence of reliable data, of course, makes it a bit difficult to assess the true prevalence of the disease and plan for effective interventions. So this is something that we have to continue to lobby for and work with the authorities to establish. Um, as it relates to curative treatment options, this is not available locally or even in the region as far as I am aware. And a lot of our patients here have not been considered for clinical trials. So families are often faced with significant financial burdens in pursuit of these advanced curative treatment and therapies. Recently, though, there was a change in the government administration in Trinidad and Tobago, in which consideration has been given to including life-limiting illnesses such as beta thalassemia major in as part of the Children's Life Fund legislation. So this is great news for us, and there is immense hope and anticipation that through this fund, families will now be able to receive financial assistance so that they could go abroad and access these curative treatment options. I have another colleague that Steve would know as well. He is from Guyana, but he lives in Trinidad, and he has a daughter as well with beta thalassemia major. And they are currently in the process of trying to get a bone marrow transplant done abroad. So hopefully they will be able to attend one of the future webinars and share more about their experience and their stories. But I know that that is something that they are working towards. Um, all in all, the challenges that we faced in the inherited blood disorder community here, it certainly continues to be of a major cause of concern for us. But we remain hopeful that with continuous efforts and networking, we could, work towards improving the care and the management and the overall quality of life for our patients. For me personally, despite the limitations experienced with the condition, I do my best to pursue a somewhat normal life. Some people tend to think that you can't do things that a normal person would do, and you'll miss out on a lot of opportunities because you have this condition. And I guess I also had that mindset for a while, when I was a bit younger, especially. But I eventually chose to not accept that for my future, and while the frequent absences from school and so on would have affected my academic performance to some extent, I was determined nonetheless to push through and to graduate, and I was ready to move on to the next level because achieving a tertiary level education and having a corporate job of my own, like everyone else, was always my goal. And I could recall even just a few years ago when I was in university, there were occasions that when I was scheduled to receive blood transfusions, and I had to attend school to write exams and to do assignments on the very same evening. But by the grace of God, I was able to do it, and my career also started in 2014, while I studied part-time at the university. So I had an 8 to 4 job, and most of my classes were from 5 to 8 during the week and on weekends. So it was definitely quite a bit to manage and a struggle at times. But with much prayers and perseverance, I was able to complete my program of study. And in 2018, I graduated with my Bachelor of Business Administration degree. And I was blessed with opportunities of employment at several organizations as well, where I function mainly in the business administration field. I'm currently in pursuit of an executive master's of business administration, and I continue to be in search of opportunities that will allow me to grow and to develop my skills and abilities. Apart from my academic and professional background, much of my time is spent volunteering for the society, where I currently serve as the vice president for thalassemia on the executive. And I use this avenue, like I said, to raise awareness and to advocate for the welfare of patients like myself who live with thalassemia and other inherited blood disorders. I've also been actively involved at my local church where I provide technological support and participate in activities of various departmental ministries throughout the year. And, these things really help me to, I guess, find purpose, and it keeps me going. I am passionate about my faith, meeting new people, indulging in cultural cuisine, and exploring, the beauty in nature. I really love nature and I find that it's so therapeutic. Um, I just, aspire to inspire those around me by enjoying the simplicity of life, really, and staying focused and just pursuing my goals despite living with an inherited blood disorder that is severe. And I believe that through the grace of God and a strong support system, a positive mindset, you can achieve just about anything. And I want to end by saying that despite your diagnosis or your circumstances or the status based on what society depicts, whatever you might be going through, it does not determine your destination and the greatness inside of you. So just have faith, believe in yourself, take care of you and your health, and go out there and conquer the world. Thank you guys so much for listening, and thank you to CAF for this wonderful opportunity. I look forward to being part of future webinars as well. Thank you so much.
Thank you, Radhika. I just want to quickly, now that you hear all about thalassemia, every year I do a care walk that raises money for research in thalassemia. I just dropped the donation link in the chat. This is my group, the New York City group. Please make a contribution if you can. And I also drop my telephone number for those people who is in New York and would like to walk with me, and my email address there, so you can always contact me. Thank you. And now I'll hand you over to Craig Butler, who is my boss, the National Executive Director for Cooley's Anemia Foundation. And he'll be moderating questions and answer. I know a lot of questions might be coming from you. Thank
Thank
you.
you, Steve. And thank you, Radhika, and thank you, Chanel, both very much for beautiful presentations. If you do have any questions you have for Radhika or Chanel, we'll be happy to answer them at this time. You can either raise your hand in the little Zoom tool, using the Zoom tools, or you can put a question in the chat box if you would prefer. And while we're waiting to see if anyone does have a question, I apologize, Radhika. At one point, my sound went out, so you may already have covered this. But I was wondering if you might want to tell people what kind of things they might need to look for if they have a child, what kind of signs or symptoms they might have that might indicate this child could possibly have thalassemia.
That's a great question, Craig. And it's very interesting. I'm listening to Chanel's story and how similar it was to mine, even though we're years and continents apart. But yeah, children with thalassemia, in the beginning, they will be as they get, into their first year of life, they will be paler and they will start falling off of that growth curve. So children are expected to grow at a certain speed and they'll be growing slower. They may be smaller. They'll definitely, like I said, be paler. They'll be more lethargic. They can be a little bit irritable too. And so what will happen is hopefully that the pediatrician will notice these things. They'll say that, you're looking a little pale and a little tired. And they would, bring this to the attention of the parents. And I see here Sonia is asking, which is a great question, could this be categorized as failure to thrive? And yes, Sonia, exactly. It can be considered failure to thrive if it's extreme, because here's the interesting thing. Chanel and I have the exact same diagnosis, but some people with thalassemia start getting transfused earlier than others. It can still be variable because there are other things that affect us. There's, our genetics are one thing, but there's our environment, our health, other factors. So there are signs to look out for, and doctors can do a simple blood test. And now I'm not sure about in Trinidad and Tobago, but in the US, thalassemia is part of newborn screening. So unless a parent opts out of it, children who are born in the United States do newborn screening. That's that heel prick when they're about 24 to 36 hours old. And it tests for a host of conditions that need to be treated promptly in order to avoid life-limiting issues. And one of those is thalassemia. So parents can find out if they are, unless they opt out of newborn screening, they may find out earlier than normal if their child has thalassemia. But great question, Craig. I saw there might be a follow-up one.
There is one, and I think this is certainly directed toward Radhika because you are a genetic counselor, but Chanel, after Radhika answers, you may have something to add as well. Carol asked, how do we educate expecting parents about this? Can testing be done during pregnancy?
So excellent question, Carol, and exactly why I'm here, because as a genetic counselor, I want people to understand that this is something you can find out even before a woman is pregnant. So we do in genetic counseling, there's preconceptual genetic counseling. So a woman and her partner can get tested before they're even pregnant to see if they're both trait carriers, to even know if they're at risk to have a child. And if they find out they're both carriers and they say, I don't want to even take the risk, they can use IVF and PGT to make sure they only have an embryo, a child that does not have the trait. They can also just go natural and get pregnant. And then during the pregnancy, they can do what's called a CVS or amniocentesis to test the baby without sticking the baby, of course, but checking the fluid around the baby for the cells to test to see if the baby has a severe form of thalassemia. So it can be tested. Either they can find out if they're at risk before they're even pregnant, and they can, like I said, go the IVF, PGT route to make sure they only have a healthy child that either is only a trait carrier or not at all, even that, or they can get pregnant and then test the pregnancy. And then based on that information, it's a 1 in 4 chance if they're both carriers. And if that child is found to have thalassemia, they can have options as to what they want to do next. So there is definitely ways to do this. And the reason why we're here today is because I find that a lot of people of Caribbean descent do not even know that they're at risk of having a child with thalassemia. And I didn't mention this before, but why this is so passionate, why I'm so passionate about this is because my husband is Guyanese. He's Indo-Guyanese. And until he met me, he had never met anyone with thalassemia. His family had never met anybody. They'd never heard of it. They had no idea. And now they're my biggest supporters. They're at every walk. They're always trying to help get the word out that, hey, this is something that exists in our land, in our people. And we want to make sure people are aware of it.
Thank you. Chanel, was there anything that you thought you should add to that?
I just want to say that it's definitely important, to test. And on the point of newborn screening, that is something that we did launch previously in Trinidad, but there were some challenges with the program. So it's something that we're working on doing again. So yes, I'm definitely an advocate for testing to make sure that you're not a carrier of the gene when family planning.
And if I may, I actually was just in Guyana a couple weeks ago, and I spoke to a young doctor there who is a family practice doctor. And I actually asked her, I said, is thalassemia, do you do any newborn screening in Guyana? And she said no. And I said, well, how would you find out then if a child has thalassemia? They said, not until they become sick. So as Craig, you had asked, very rightfully so, what are the signs? And it isn't until a child becomes sick and they're not growing and they're very pale and feeling unwell that, unfortunately, in her experience, that's how, children with thalassemia come to medical attention. So
Thank you.
It's unfortunate, but hopefully we can change that.
And I do see that Joseph has his hand raised. I think, Joseph, would you like to ask a question?
Yes, good night, everybody, and good evening. I joined a little late. In fact, today was the first time I learned about this condition and through a Caribbean network I am in. I'm calling from Grenada. I mean, the island of Grenada. And I was going to ask a question in relation to the Caribbean, and the previous speaker spoke about Guyana. Is that known? Is that condition known in other territories or other islands or other countries in the Caribbean? And is there anything that's been done to sensitize people? And is there a particular group of people that are prone to develop that? Just as how you have glaucoma, which affect a certain sector of the population, or diabetes or so. Is there a particular group that are affected more than others? Yeah? I hope my question makes sense. Thanks.
So Craig, I'm happy to answer that if that's
Sure.
okay, unless Chanel,
Absolutely. You go right ahead.
unless you want to, Chanel, I don't want to step on toes. Oh, she's saying to go ahead. So Joseph, that's a great question. And I know you said you joined a little late. So as I mentioned previously, the most interesting thing about the Caribbean is because whether we're talking about Guyana or Trinidad, Barbados, Grenada, any of the great countries in the the Caribbean, what makes it really special is the fact that it's one of the most ethnically diverse areas in the world, and that what you're saying in Grenada, you have people who are of African descent as well as people of Indian descent and of Asian descent and of European descent because of colonization and the indentured labor and the transatlantic slave trade. So you do have a mix of people from all of those regions. And thalassemia, the condition we're talking about today, is prominent specifically in people of Asian descent. So when I talk about Asian, I mean Indian, Chinese, Pakistani, but it's also seen in people of European descent and of African descent. So all those populations that are present in Grenada, in Trinidad, in Guyana, in Barbados, in St. Lucia, St. Kitts, Dominica, all of those populations that are present are at risk for thalassemia because of their ancestral connections to India and China and Africa. So it is something that people in Grenada are at risk for. They themselves, like I said, would be healthy, but if their two carriers get together, they could have a child with a more severe form, like Chanel and I both have. And the reason Chanel and I are both here today is because we were fortunate enough to get diagnosed at an early enough age and get appropriate treatment. That is really, really critical. And as Chanel has told you, it was not always easy for her. And I can tell you, it was not always easy for me as well. And just like what happens in Trinidad, same thing in the US, we have a blood shortage constantly. So it's really, really hard, not only to get the blood we need, but also to get the doctors that are aware of this condition and know how to treat it properly. So I'm sure in Grenada, the same problems are probably there as well. So what we need to do is advocate and educate.
Okay, so we have
Could I
time.
ask another question in terms of could the condition be misdiagnosed since people are maybe not aware, maybe even practitioners, healthcare practitioners are not aware, they might misdiagnose this for something else? And
Absolutely.
would you folks be willing? I lead an organization known as Friends of the Earth Grenada, which is an environmental activist organization. And I've engaged in a number of activities, not just strictly environment, but anything that affects the human being, whether it's human rights, whatever, and health. Even when COVID came in, we were the first group to sort of engineer a conversation on COVID when everybody was kind of timid about saying anything. In this case, with thalassemia, I hope I'm pronouncing the word properly, because today is the first time I come into touch with the word. Would it be possible that I could get some assistance from you to having a similar exercise like we're having now for people in Grenada and probably the other islands? Is it possible? So to make them aware, to bring the knowledge that this is something that we should be aware and look for. Because I'm asking that question against the background, like we have all kinds of situations arising now through climate change and so on, and it would exacerbate certain conditions that might need special attention. Where, for instance, if you have a hurricane or something like that, you need to be able to to serve people who have these conditions?
So that's actually a very long question, which deserves a very long answer. And I'm just going to, unfortunately, have to give it a short one. So, Thalassemia Foundation is basically U.S. focused, but there is an international organization, the Thalassemia International Federation, which would be a good place to contact if you're wanting to see about getting maybe some specific intervention in Grenada. But there is information available on the Thalassemia Foundation website, which can be used. It applies to everyone that has thalassemia or that comes from a population that is disproportionately represented amongst thalassemia. And that might be a good place to start, is seeing what's available there that might be able to be shared with officials that you might have knowledge of in Grenada.
So I just I dropped a question in the chat box from someone who is on the call.
Why didn't beta thalassemia show up as diagnosed until certain ages, and what are the complications from age 7? I'm sorry, and what are the complications from iron overload?
Is that the question, Steve?
Yes.
Okay. So as I mentioned in my slides, there's two, when we're talking about beta thalassemia, there are two severe forms. One is called intermediate, one is called major. Chanel and I both have the major form. And when you have major, you start transfusions usually before 2 years of age. People with intermediate start transfusions later because they are able to make some functioning hemoglobin, that part of the red blood cell that carries oxygen, and therefore are less anemic. So my thought process, not knowing any blood work and seeing anything about this particular person, is that if they didn't get diagnosed till 7 and were able to survive till 7, they likely have the intermediate form. And with intermediate, again, they do need transfusions because they make some, but not really the right amount. So they get transfused, just not as frequent. But they, again, can develop that iron overload. And iron overload, as I mentioned, iron deposits in all of our organs when you are getting transfused so frequently, unless you use that chelation medication that Chanel spoke so eloquently about, that both of us are going to be stuck utilizing as long as we get transfused. We have to take our chelation medication, because if we don't, the iron builds up in our heart, it builds up in our liver, it builds up in our pancreas, in our thyroid. It can even affect our sex organs, so our ovaries, and our testes. So all those organs it'll affect, and then it'll cause damage. So with the heart, especially when that's a real big magnet for the iron. And when the iron is building up in the heart can't pump like it should, and it gets weaker and weaker. And oftentimes people who don't have their iron overload controlled or removed, the heart eventually stops functioning and they die of heart failure. So iron overload is really, really dangerous if it's not properly managed. And that's why, we need the blood to survive, but the blood causes the iron overload. And then we need the chelator to keep the iron out of us so that we can live, as I think Chanel said, a great, quote unquote, normal life.
So thank you, Radhika, very much. And Chanel, there have been great questions. Unfortunately, we're running out of time now, so we're going to have to draw things to a close. If you do have questions which we weren't able to get to, if you can send them to Steve, we'll do our best to answer them so that we can make sure that you get the information that you need. And on behalf of the Foundation, Radhika, Chanel, thank you so much for sharing your stories and your wisdom and your experiences. And thank you everyone here who has been able to tune in and let us communicate with you about something which is so important to us and to so many communities. Steve, is there anything that you would like to add before we sign off?
No, just someone from Guyana is saying the same as Chanel, that the care in Guyana is not the same. And during the COVID, they had a difficult time getting blood.
Yep.
The quality of care for people with thalassemia in Guyana is substandard. And thank you all very much for attending.
Appreciate it, all of you. And we'll just leave you by saying, if you are able to donate blood and you do not, we encourage you to please go out and donate blood as often as you can, not just for those people that have thalassemia, but for everyone. Blood is so important, and it's not something that there's a substitute for. So thank you all, and thank you for joining us tonight. Take care.
Thank you.